Hi, in the following 10 minutes I'm going to talk to you about total ankle arthroplasty. It is estimated that 1 in 7 people in the United States suffer from osteoarthritis. Primary OA is rare, occurring in only 7 to 9% of the cases. Secondary OA is much more common. 78% of these cases occur from trauma, with malleolar fractures being the most common. Ankle injury is 9 times less likely to occur than a hip or knee injury. The ankle bears the highest load per centimeter squared, so the potential of injury is substantial. Arthritis is debilitating to this joint and will decrease joint space. This will eventually result in increased bone surface articulation, leading to decreased joint congruency and loss of proper function in the joint. The primary indication for surgery is severe or end-stage arthritis. Commonly, the decision is made between the patient and orthopedic surgeon, although it is not unlikely that the healthcare providers will assist. Patients can be determined appropriate for surgery by looking at the indications and contraindications. There is little evidence to support conservative treatment in the place of TAA. Long-term, patients will experience pain but still remain functional. Also, patients may return to recreational activities. Although there is limited evidence on the outcomes of conservative treatment in the replacement of TAA, there are many interventions such as activity modification, weight loss, medications for pain and inflammation, bracing, orthotics, and rocker bottom shoes. The goal of conservative treatment is to reduce pain and delay the need for surgical intervention. So a little history of arthroplasty. The first generation had limited range of motion and increased stability, but lacked joint congruency. Many had a high failure rate. Second generation arthroplasty had a variety of designs, including 2 and 3 component designs. Pyrich et al. Showed the 2-component agility design to be superior, with 95% claiming they would repeat the procedure and 79% being extremely satisfied. Here's some types of surgery. Arthrodesis is a surgical fusion of joint surfaces and is considered the gold standard by many. It is more stable and durable, but results in a stiff foot, inability to change the height of the heel, greater stress on the knee and hindfoot, and little to no range of motion. TAA. Arthroplasty is an artificial reconstruction of a joint. It restores a more normal gait pattern and increases range of motion, but has a higher complication rate and questionable durability. There are many possible indications for TAA, but let me draw your attention to a few important ones. First, people older than 55 had better outcomes than younger people, as was found in one study. Also, it is best for people to have low physical requirements in both work and leisure activities before receiving a TAA, as well as a good neurovascular status. Related to this, diabetes mellitus is neither an indication nor a contraindication, and each patient should make the decision with their surgeon whether their vascular supply and healing potential are right for surgery. Finally, arthritic degeneration is a common indication for TAA. Important contraindications include people with high physical demands, poor distal vascular supply or neuropathy, and finally, normal surgery contraindications such as infection. One study compared TAA and arthrodesis and found that TAA had a low implant survival rate at just 62% after 10 years. This study included results of the 3 different types of implants. There was also an 8.8% infection rate. Arthrodesis leads to decreased range of motion, which will lead to arthritis of the surrounding joints. For ankle arthrodesis, the talonavicular and subtalar joints specifically were affected. After 22 years, there's a 91% rate of adjacent joint arthritis. A long-term outcomes study found that arthrodesis and TAA had similar mean AOFAS scores and the same % good or excellent results. The main difference found was that arthrodesis had a 5% below knee amputation rate, while TAA had a 1% below knee amputation rate. Basically, the evidence has shown that there is no ideal candidate for TAA, and so comparing the 2 types of surgery is not beneficial because indications for the 2 types of surgeries vary. Also, the reviews conducted of these 2 types of surgeries were mostly of uncontrolled case series, and so higher level evidence is needed in this area. Okay, so before we get into more research, let me talk to you about some common outcome measures. First, we have the AOFAS as mentioned earlier. This is the most common outcome measurement used in the following studies. It is region specific to the foot and ankle, with the ankle hindfoot section being used most. Next, we have the COFED, which is similar to the AOFAS since it's region specific to the ankle, but provides less emphasis on function and more on the pain outcomes. Next, we have the SF36, which is a general population quality of life outcome measure which encompasses 8 different domains of life. And lastly, we have the visual analog scale, which should be familiar to all of us by now. So first, we have the study by Haddad in 2007, which looked at arthrodesis and TAA at 5 and 10-year survival rates of the implant, as well as the AOFAS scores, and found that there was no significant difference in any of these values. This next study in 2009 found significant improvements in AOFAS, gait speed, step length, cadence rate, functional range of motion, and energy expenditure from pre to post testing of TAA. The Espargoza study compared TAA and arthrodesis as well and found that TAA significantly improved their AOFAS scores and SF36 scores, while arthrodesis only significantly improved their SF36 scores. A 2012 study by Grayson compared TAA to healthy ankles and found that those with TAA had significantly lower SF36 scores than their healthy ankle counterparts, which is what we would expect when we are replacing a joint. Another 2012 study by Shu compared TAA and arthrodesis in the active population. This active population included recreational as well as competitive performers. This study found no significant difference between TAA and arthrodesis on patient satisfaction, activity level, the UCLA, or AOFAS scores. These are some tests and measures that should be assessed when working with a post-op TAA. Though these are in alphabetical order, they should be sequenced according to the patient's condition. A few measures I'd like to point out are gait, observation, and sensory exam. With gait, you can expect the patient to be on a non-weight bearing restriction for a minimum of 6 weeks and to have a CAM walker/walking boot for the first 3 to 6 weeks. Skin assessment is crucial because one of the most common TAA complications is delayed wound healing, so make sure to do a thorough skin assessment after each treatment session. Sensory testing is also important following TAA surgery because the deep peroneal nerve may be subject to damage during the operative procedure. You'll want to assess the anterior and lateral compartments of the lower leg bilaterally for any leg discrepancies. Moving on to intervention, you'll want to start by managing the patient's pain and edema by means of pain or anti-inflammatory drugs, rice and/or physical agents such as the Game Ready. Again, as stated on one of the previous slides, facilitation of wound healing is crucial for proper recovery of these patients. This can be done by performing soft tissue mobilizations and by educating the patient on self-massage techniques and the role of proper care and hygiene of their scar. Range of motion and strength, as with any postoperative procedure, will most likely be diminished. During the initial 6 weeks, range of motion and strengthening exercises should only be subjected to the unaffected joints. After the immobilizer has been discontinued, the patient can then progress to active and passive range of motion, stretching and long sitting to target the plantar flexors, and strengthening isometrics, low-intensity exercises such as the ankle four-way as seen in the picture on the right. We'd also want to improve the patient's balance and proprioception and gait mechanics based on their weight-bearing status and assistive device. The BAPS board is a good way to regain the patient's balance and proprioception and can be progressed from sitting to standing within parallel bars. We'd want to work on developing proper gait mechanics with minimal compensations to progress to normal ambulation. Stair training may also be indicated depending on patient's work and/or living conditions. As far as maintenance of the prosthesis, patients are advised to avoid high-impact sports such as basketball, baseball, and soccer. Instead, they are encouraged to stay physically active by participating in low-impact sports such as golf, swimming, walking, and biking. So what is our clinical bottom line? An implant with consistent and long-lasting outcomes has yet to be identified through research. However, with new implants that mimic true ankle biomechanics, TAA should yield more favorable outcomes with a higher implant survival rate. And these are our references. Thank you for listening.